newer insights into pathobiology and biotherapeutics. That's what I'm going to talk to you in the next few minutes. So you look at this case, a 24-year-old female who came with blood and mucus in the motion since 3 months, and on colonoscopy had only ulcerative proctitis. See here? And then we gave mesalamine 1.2 grams BID oral along with mesalamine suppository. Patient's symptoms reduced, but blood and mucus still occasionally occurred. So sigmoidoscopy showed persisting inflammation here. And then mesalamine rectal suppository was added. After that, everything improved. And there's very little inflammation here. But look at the biopsies. Still, there is dense inflammation here, which means endoscopy. Patient is asymptomatic. Endoscopy shows tremendous improvement. No more blood and mucus, no tenesmus, nothing. But the biopsies show dense inflammation still going on, which means the disease can relapse at any point of time. So hence, the goals of IBD therapy should be to achieve sustained remission, which leads to better long-term outcomes. So goal is remission is one, and then deep remission. Deep remission is histologic remission. Biopsy should show no inflammation there. It should show quiescent, healed mucosa. That is deep remission. That is what today we want to achieve. And clinical parameters, reduced symptoms, improved endoscopy results, mucosal healing on endoscopy. Outcomes, improved quality of life, reduced hospitalization, avoiding complications like cancer or surgery, and that is the sustained disease control. And you see here, the IBD has got three things. One, inducing remission, which could be clinical and endoscopic remission. And then maintaining remission to prevent complications. And the third is maintain deep remission of steroids, which means there should be histologic remission without steroid. That is deep remission. So ulcerative colitis, we showed three things in the last presentation, but today there are four. One is the genes, then the environmental factors also have been brought in. This is Nature Reviews 2016. Which shows genes, environment, and then there is gut microbial dysbiosis, and then there is an immune system. All these are in play. So here you see all these cells, the ILCs, the NK cells, the natural killer cells, natural killer T cells, the Treg cells, are suppressor. They suppress inflammation. T effector, helper T cells increase the inflammation. B cells which produce antibodies, the secretory IgA. Then you have dendritic cells, macrophages, monocytes, neutrophils, and even adipose tissue is an endocrine organ which keeps pumping out TNF-alpha, interleukin-6 and everything, cytokines. So endothelial cells, platelets, all of them contribute to cytokines. Some of them contribute to chemokines, the fibroblasts, and then the neuropeptides. All these and the epithelial cells themselves can produce chemokines. All these together produce a mess of a situation in ulcerative colitis. That is what you have to remember. Okay, so the pathogenesis is depending on the microbiome. Here, what are called pathobionts or pathologic bacteria. Examples are ruminococcus, proteobacteria. All these are pathogens. They are pathobionts, pathogenic organisms which are found in abundance in ulcerative colitis as compared to Clostridia, not the difficile, the Clostridia sindens, Clostridia sporogenes are friendly bacteria. These ameliorate inflammation. Faecalibacterium prosnitzi also, this produces short-chain fatty acids. And from the food that we take, the complex carbohydrates are broken to short-chain fatty acids. This protects the gut mucosal barrier. So here in ulcerative colitis, the pathobionts increase, the symbionts decrease. Then inflammation, effector T cells, the dendritic cell activation, anti-TNF, TNF, and then the anti-commensal antibodies are more. And those cells which suppress inflammation, like Treg cells, in IELs, the lymphocytes, intraepithelial lymphocytes, they're protected. So that is why if there is an inflammation going on, you will see intraepithelial lymphocytes are more. So the IL-22, IL-10, IL-interleukin 18, 10, and 22 suppress inflammation. Mucin 2 secreted by the goblet cells in the colonic mucosa. And the tight junctions maintaining the gut mucosal barrier, energy, all these protect, whereas they all are less. And here the inflammatory cells are more. And so what happens is the dysbiosis and inflammation. Dysbiosis causes metabolites which trigger inflammation. And then there is a vicious cycle going on. And also the short chain fatty acids like propionic acid, butyric acid, all these are protective indoles or protective secondary bile acids like deoxycholic acid, lithocholic acid, protective. All these are low, and the primary bile acids, single lipid amino acids are high, which can trigger inflammation. So this balance. So we are now looking at an era. We are looking at metabolomics. It's a omics era. So a lot of exciting new things are happening in this field. So post microbiota interactions in IBD is a new article in July 2020. So Nature Reviews, look at it. So it's beautiful. So beneficial effects of symbionts. Our intestine, see this left side is the small bowel. Here there's a large bowel. The small bowel has a thinner mucus layer, whereas a large bowel has got a very thick mucus layer because it has got plenty of bacteria. So generally we find good bacteria. If you're taking more vegetarian food, you get a lot of good bacteria because the complex carbohydrates, and especially onion, garlic, and all those things like apples, pears, and all those complex carbohydrates lead to production of good microbiome in the mucus layer of our intestine, and compared to people who are continuously taking only non-vegetarian diet. So more vegetarian foods and especially complex carbohydrates are helpful, like which increase with food items which are more fast, fructooligosaccharides, inulin, and they're all good, like pears and artichoke and such things increase the short chain fatty acids and other substances which help in the symbionts, which are friendly bacteria, Akkermansia, Mucinifila. So it's one example. There are multiple of them. So these bacteria keep on talking to the subepithelial lamina propria inflammatory cells. They're all there. These are all defense systems. So this is in the small gut, but we are looking at the large intestine. So these keep communicating either between the tight junctions, between the cells, or transepithelial also passage is possible. Some of these byproducts can go down into the subepithelial layer, which keeps in sending stimulus to the T cells, the dendritic cells, and all that. So these are the B cells, and this is the T cell, and these are the dendritic cells. They are in close association, talking to each other all the time. Is this bacteria a bad guy or a good guy? If it is a bad guy, immediately the B cells become plasma cells and produce dimeric IgA, which is secretory IgA, which just gets into the mucus layer and prevents the bacteria, the bad bacteria, from coming anywhere close to the brush border. See, this is the stirred mucus layer. This is the unstirred mucus layer. The unstirred mucus layer does not allow anything to come in. And this is produced by the goblet cells of the epithelium. So that is why the MUC2 is important. So the goblet cell keeps on pouring out mucus. So this is corroded and depleted. So you see in ulcerative colitis, the pathologist will say goblet cell depletion. That is a bad story because the mucus layer is not there. So the bacteria can come close to the epithelial layer, can produce erosions, ulcerations. That is how the disease happens. And see here, the short chain fatty acids produce a host of good effects on the mucosal barrier, also training the immune cells. So regulatory T cells support the intestinal homeostasis here. And there are what are called mucosal firewalls. These are new terminologies in 2020. So the left side is the small bowel where there is a Peyer's patch, whereas here there is no Peyer's patch. And so we will look at only the large bowel. You see here, the large bowel. So right from the subepithelial layer, if there are any bacteria which come in, the dendritic cells will identify and give it to the helper T cells, which will kill them, and also stimulate the plasma cells to produce dimeric IgA, which will go and fight. And even the white cells, the T cells can transmigrate into the mucus layer, also can fight. So like dysbiosis in the IBD, there is an early phase and a late phase. Early phase, where there is a genetic and environmental factor, both are important. So in a genetically susceptible individual, the environmental factors which alter the gut microbiome, which increase the growth of pathobionts, which produce a damage by stimulation of the inflammatory system. And then what happens in the late biosis, the inflammation is perpetuated here because of all the chronic bacterial invasion and also their metabolomic products which migrate and keep on triggering the inflammatory system. So what happens initially, the food antigens, the gut microbiota, the pathogens, the MAMPs and the DAMPs, which happens because of the dying cells can produce the DAMPs. So all these molecular patterns can stimulate the inflammatory system. And then this inflammatory system again gets re-stimulated by the dying cells. So the PAMPs and MAMPs first stimulate, cause inflammation, and the dying epithelial cells produce DAMPs, which further trigger there's a secondary response, tertiary response, and a self-sustaining immune and non-immune inflammation and fibrosis, which goes on and on and on unabated in ulcerative colitis. This is what happens. So first thing that happens is genetically susceptible individual, the environment in the form of food antigens and bad bacteria, the pathogens, the pathobionts, they produce an inflammation, and this inflammation is perpetuated by these and also by the dying epithelial cells which produce DAMPs, and then there is a persistent inflammation that goes on. So there is a beneficial microbial species that decreased short-chain fatty acid producing microorganisms, and a reduction in the tryptophan metabolism. All these are associated with inflammatory bowel disease. So what are the newer therapeutic goals in UC? You modify the long-term course of ulcerative colitis. We're not looking at a short-term mucosal healing and a patient symptom response. We want to heal the mucosa, keep it healed in the long time. And the complete and persistent healing of bowel mucosa has to be aimed at with a deep remission or histologic remission, avoidance of complications, avoid hospitalization, surgeries, ICU stay. So the benefits are improved cost to efficacy ratio and an improved quality of life. So has the practice changed? Is the next few minutes that I'm going to show you. See, this is originally we started with mesalamine, budesonide, that is to induce remission, and then we maintained remission with mesalamine. If the patient did not respond, we started systemic corticosteroid, and then on a maintenance we took up thiopurine, and then if still it doesn't respond, we went for anti-TNF alpha, anti-integrin, along with the this thing like azathioprine. So the thiopurines. So as I told you, thiopurines alone are not good in the long run. I'll show you some data. So if there is a thiopurine for short time is okay, but then you have to add a biologic, stop the thiopurine, continue on biologic itself. So anti-TNF or anti-integrin can be given for maintenance. So, and then investigation agents and surgery comes later. This is a conventional approach from mild to moderate severe disease. Whereas today we are treating the disease, the inflammatory stage, which goes into stricturing stage and penetrating stage in Crohn's, or fibrosing stage and complications in ulcerative colitis. So high potential to prevent these complications in UC also is to treat early with biologic therapy rather than the stage in which we are treating now. This applies both for Crohn's and ulcerative colitis. So combination with the biologic with azathioprine is better than monotherapy. Early therapy, earlier the biologic better than the late therapy. Well-timed surgery is okay. So what are the TNF alpha agents for ulcerative colitis? Inflixi, adalimumab, and Ceto didn't come into India. Cetolizumab pegol, but we have these two. This has been there for almost 2 decades. This is there for almost like 1 decade and more. And so these biologics, Inflixi is an IgG monoclonal antibody directed against TNF alpha. And then this is the only problem is the IV infusion. You have to give it intravenously. You give it at day 0 and week 2, week 6. And then every 8 weeks, you have to give 5 milligrams per kilogram body weight. On a 60 kilogram adult, you give 300 milligrams of infliximab, 0, 2 weeks, 6 weeks, and then every 8 weeks. This is one way. Or you can give adalimumab, which induces remission at 120 milligram subcutaneous initial. After 2 weeks, give 80 milligram. After 2 weeks, you give 40 milligram. And every 2 weeks, 40 milligram. But this can be taken subcutaneous. That is one advantage here. So we have head-to-head trials now, which look here, combining the two trials, Act 1 and Act 2, and Ultra 1 and Ultra 2. This is for IF infliximab. This is for adalimumab. These combination studies found that a clinical remission rate was higher with Inflixi, response rate was higher, mucosal healing was higher for inducing remission. But whereas for maintenance of remission, there was not much of change. So the newer biologics, you have vedolizumab, but before that, you should understand where they are acting. So we are all dealing with vedolizumab. See this. This is, here, the infliximab, adalimumab, certolizumab, pegol, or block the TNF-alpha, which is being released by the pro-inflammatory cells. Whereas tocilizumab blocks interleukin-6. And this is the tofacitinib, which blocks the JAK pathway. We're doing trials on tofacitinib in our own hospital at the moment, so on inflammatory bowel disease. And then there are others like vedolizumab, which prevents the rolling in of the inflammatory cells from the vascular endothelium into the mucosa. So this goes through the MADCAM pathway. So there's an anti-MADCAM pathway. So, and then you have ustekinumab, which acts on the IL-23, which is not common. But Vido is available in India. So we have today Inflixi, adalimumab, and vedolizumab in India. But I think tofacitinib will soon come in, which is advantage of the oral formulation. One tablet a day will be sufficient. So Vido, is one that, generally for an inflammatory cell to act, it has to go through the vascular endothelium out into the mucosa, rolls out, and then produces cytokines and chemokines. So this vedolizumab blocks the exit of these, inflammatory cells from the vascular endothelium. It goes through the, the alpha-4 beta-1 integrin pathway. The MADCAM pathway is here, but this goes through alpha-1 beta-4 anti-integrin pathway. So that's how it goes through. And see, the vedolizumab results are quite impressive. You see here, clinical remission even in patients where people have been treated with TNF-alpha antagonists like Inflixi or adalimumab, and then patient failed, and now you switch to vedolizumab. Clinical remission is close to 40%. And if in naive patients unexposed to TNF-alpha drug, anti-TNF-alpha drug, it's even close to 47.9. And the results are very good. And we have treated on a global platform, we are treating patients for the past 13 years with, vedolizumab. In ulcerative colitis, the results are excellent with no side effects. So it's a good drug. So probably today, it could be a first-line drug in treating ulcerative colitis. So it produces a durable clinical response. So from clinical remission to, clinical remission, it keeps increasing from TNF exposed to the TNF night, and then it produces a durable clinical response. So it's very good, 65% to 56%, but a durable clinical response by 52 weeks. So that's quite good. And then head-to-head trials are on between different molecules, Inflixi and others. So from the step-up approach, now the step-down approach is what is thought to be the best. So you start with Inflixi and then step it down to Inflixi alone. And then you can give low-dose steroids or locally acting steroids and mesalamine and maintain the patient. So safety consideration, they are safe. And see, biologics, only thing they're expensive. That is the only problem. So previously people were scared of lymphoma, but the lymphoma risk is extremely uncommon. And except for sometimes the infection rate can be up in infliximab, but the mortality is not increased in infliximab. It's the steroids which increase the mortality. So steroids are the culprit. And then again, so optimizing the biologic therapy is of paramount importance. So you should not produce a peak and, a trough. So if it falls below the target line, then the efficacy is gone, the drug level is not available, then, the patient can develop antibodies against these, the TNF alpha antagonist. So then the TNF alpha antagonist is no more effective. So proper adherence to the dosage is important. So you'll have to maintain a peak above the 10 microgram per ml of the plasma level. So that is the best for biologic therapy. You have to keep it below. So this has to be below 10 microgram per ml, and then it should not, go up. So, and should not fluctuate. So if it is below 10, then that means the patient will not respond. So you have to keep it above 10. So don't give this sudden drops below 10, so that if they don't take up the proper dosing on proper timing, the drug efficacy can go down. That's what it shows. So I'm just skipping all these slides. This shows on the trough, and how to optimize biologic therapy. That is of 2020. We have a lot of data here. If people who maintain the biologic trough levels had very good sustained response when compared to those who did not. So when to introduce biologics? So the clinical trials have started after the prednisolone. That is in severe cases, moderate to severe. But today, we should probably start biologics even before trying steroid. If the patient does not respond to 5-ASA and oral budesonide, they are unable to maintain on 5-ASA, I think that is a time to try biologics if the patient can afford. So you can start biologics in select cases, earlier the better, and in patients that need them. And short-term combination therapy with a therapeutic drug monitoring if possible. So this will help in amelioration of the disease and better therapeutic response. And look at the malignancy. It's the thiopurines which produce malignancy, and the lymphoma rates you see here. The lymphoma rates do not go up with the addition of TNF alpha. So it's a long-term azathioprine or thiopurines produce problem, not truly the TNF alpha drugs. So biologic therapy is not the be-all and end-all. So you can, here in this case, I've used endoscopic therapy for continued bleeding. This is my invention of endoscopic use of chemoseed spray, which is a collagen powder. And look at this, patient came to us with acute bleed. It's a known case of ulcerative colitis with a flare. And then I just sprayed collagen through colonoscope and see here how the healing has happened. Second time, this is, you see here, in 7th month of 2019. And here we are seeing a 10th month in 2019. Beautiful healing. And, this has started healing. So gave one more course and then the patient has gone into deep remission. So you can use what are called anti-inflammatory drugs, which are called small molecular drugs, small molecules. This is the new thing. The small molecules are different from biologics. Their molecular weight is smaller. And I'll show you the example. So these can easily go across the barriers. And this is the tofacitinib, which is a JAK inhibitor, which is a small molecule and not a true biologic, because by weight, it is smaller, less than 1000 kilodaltons, whereas here, 1000 daltons, here it is more than 1000 daltons, the biologics. So these are small molecule drugs, the SMDs, this is tofacitinib, which is an oral drug which goes through the JAK pathway, JAK-STAT pathway to, prevent the inflammation. So oral tofacitinib has done very well in the clinical trials. Even our patients are on tofacitinib clinical trials for the past 2 years. They're all in remission. They're doing very well. See the 78% remission rate. So probably this will come in future. Lot of small molecules are under trial now. So filgotinib is also one another drug, and multiple other drugs are in trial. So now we go on to microbiome-based therapeutics from FMT, fecal microbial transplantation, and antibiotics which kill the bad bacteria, probiotics which help in the colonization of friendly bacteria, prebiotics which help in the colonization of probiotics, and specific drugs that target metabolic pathways, and then the synthetic microorganisms, there's a new area altogether, and tailored diet to shape the microbial composition is also coming. These are all the exciting areas in future therapy. So we can, this is the final slide I want to stop here. So I showed you first at the beginning the IBD pathogenesis. So you can give bacteriophage therapy. to kill the pathobionts. You can give probiotics, fecal microbial transplant, and prebiotics to, uh, you know, enhance the friendly bacteria or the symbionts. You can give biologic therapy to suppress inflammation, or you can use also diet like high fiber diet, tryptophan based diet, topical butyrate, that is again the short chain fatty acid, tryptophan metabolites can all be given more and tailored in a tailored fashion so that the short chain fatty acids, the indoles, the secondary bile acids are more, the pathogenic bile acids and amino acids and aromatic amino acids especially are less, so that there is an amelioration of inflammation. So my friends, I'll just stop here to say that today we are living in an exciting era. What are called live biotherapeutics are also on. I have a lot more slides, but I'm not going to show you more because of want of time. But live biotherapeutics are engineered probiotics, which can go and act specifically. I'll just, if you want, I'll show one slide on biosensors based biotherapeutics. And this is an interesting area. You see here, that is a, see, this is the epithelium here. And then the epithelium produces these inflammatory biomarkers. These inflammatory biomarkers in ulcerative colitis go and stimulate the bacterial, DNA, which to produce a reporter molecule. So here it's a fluorescent reporter molecule, which can be easily picked up. So you can use biosensor bacteria. You can sense if there is inflammation. And then you can constitutive biotherapeutic can also be given. So you can produce, this bacteria can be given, which can produce a biotherapeutic substance. It keeps on producing. It colonizes there and the mucus keeps producing. Induced biotherapeutic. Whenever you want, it can be induced from outside by giving a drink. You can stimulate the release of biotherapeutics. And a sensor-based response also. So you have if there is inflammation, it produces a biotherapeutic. If there is no inflammation, it will not produce a biotherapeutic. These are all exciting areas today.
Sir, thank you very much. And we do have few questions. One is Dr. Krishnan asking from Rajasthan. Sir, how do we manage this patient in a primary healthcare setting?
Okay, this is very simple. So first you'll have to see if the patient has got a mild disease, moderate disease, or a severe disease. You don't have an endoscope, don't worry. But go to the Mayo scoring system. The Mayo scoring system will, clinical scoring system. And a global assessment score will guide you. Is it a mild disease, moderate disease, or severe disease? For example, a mild disease is one where the patient is absolutely stable. The hemoglobin drop may be there by 1 or 2 grams. He passes 3-4 motions mixed with some blood and mucus. No problem. Start with high dose mesalamine. I start with 2.4 grams of mesalamine in the morning, 2.4 in the night. So 4.8 grams. Combined with that, I give some enemas in the form of 5-ASA enemas or even entoform enema, like a steroid enema in the morning and a mesalamine enema in the night. And then I'll just watch. But before that, one rider is you'll have to establish the diagnosis of ulcerative colitis. For that, we need to send the patient for one colonoscopic examination at least. Without that, you cannot treat. So once at least a colonoscopic examination is a must because many diseases, as I showed you, can present with blood and mucus diarrhea.
Thank you, doctor. We have a similar question from Dr. Prashant Ji, as well as Dr. Mary Regi, and Dr. Prashant is from Tamil Nadu. He has asked, what is the dietary advice for these patients, sir? And Dr. Mary Regi from Karnataka has asked, what is evidence-based diet for UC?
As I told you, a diet that improves the colonization of friendly bacteria, the symbionts. So, onion, garlic, pears, apples, artichokes, all these can improve the symbionts, the friendly bacteria. And a vegetarian diet with complex carbohydrates is always a rich source of improving the symbiont colonization, reducing bacteria that produce aromatic amino acids and help in other branch chain amino acids and others. So this is of paramount importance. A good vegetarian diet always helps. The butter, people have shown that omega-3 fatty acids contained in the butter can ameliorate inflammation. Also, one another thing is that curcumin in turmeric can also suppress inflammation. So we use curcumin. There are a lot of trials which showed the use of curcumin, at least 500 milligram to twice a day or 1 gram in a day of curcumin, along with small quantity of pepper, can improve the absorption of curcumin 1000 fold. So, like turmeric can also help. So turmeric, like you can give in a small quarter glass of milk with turmeric powder and a pinch of, pepper, like 5 grams of turmeric powder with 5 milligrams of pepper, 100. So that is enough. If every day it takes, it can ameliorate inflammation.
Thank you, doctor. And also, we have Dr. Sheikh Muhammad from Tamil Nadu asking, what are the biosimilars that are found in UC? Are they safe?
Yes, biosimilars are less expensive, and both Inflixi biosimilars are there, adalimumab biosimilars are there. They don't have much difference when compared to the originator molecule. So they both can be used. Originator molecule is more expensive, biosimilars are less expensive, but efficacy-wise, they both are same.
Correct, sir. Dr. Prashant Ward from Maharashtra is asking, can you please name the most effective biologicals to be used in management of UC?
I showed you there are two biologics which are presently available, infliximab and adalimumab. Inflixi seems to be better than adalimumab, at least by 15 to 80%, 18%, 15 to 18% in inducing remission. That is why, if you see the guidelines, say the American Gastroenterologic Association 2020 guidelines, you can refer. So you can go for ulcerative colitis management guidelines, AGA 2020, Google search. It's free for observers, and they've shown that to induce remission, Inflixi is better than adalimumab. But to maintain remission, you can either use Inflixi or adalimumab. Inflixi, you'll have to call the patient for infusion. It's 0, 2 weeks, 6 weeks, every 8 weeks infusion. Whereas adalimumab can be injected subcutaneously. That is the only advantage of adalimumab. But for inducing remission, the guidelines have recommended Inflixi. And then you can move on to adalimumab or infliximab for maintenance. But today, the new drug which has come into Indian market in the past 3 months is vedolizumab. That is scoring over both the biologics. That's even better by all means in the trials. The efficacy rates are much better than the Inflixi and adalimumab. The vedolizumab is more efficacious.
I have another question from Dr. Arun Dhotra. The questions are coming so many right now, sir. It's very difficult for me to keep a track. But still, Dr. Arun Dhotra from Jammu Kashmir is asking, how frequently should we do colonoscopy in patients with UC in remission?
How frequently we should do colonoscopy? Yeah, okay, I told you it's very simple. Annually, one flexible sigmoidoscopy, because I told you this doesn't happen, the skip lesions do not happen generally. It's a distal disease which goes proximal. So just a flexible sigmoidoscopy, if distally in the left colon is okay, even in a pancolitis, you can assume the whole colon is all right. So annually, a flexible sigmoidoscopy. Every 3 years, we do a colonoscopy. And then I told you two markers which can be very useful. One is C-reactive protein in the serum. And the second one is fecal calprotectin. If the fecal calprotectin levels are below 50, and if the C-reactive protein is below 5, that means there is no inflammation. So this is the same answer for the person who asked the first question. In a primary care setting, how to do differentiate. So from, if there is blood and mucus, definitely both of them will be raised. So that cannot really help. But if there is a diarrhea, you want to know whether there is mucosal inflammation and injury, then you can do fecal calprotectin and C-reactive protein. So monitoring can be done frequently also with fecal calprotectin and C-reactive protein. If the CRP is below 5, fecal cal is below 50, that means the disease is in remission.
Sir, we have Dr. Jalil saying wonderful and lucid presentation to Dr. Prasad. And we have two questions on exclusively enteral nutrition. How useful in IBD?
Yeah, exclusive enteral nutrition is more useful in Crohn's disease than even the ulcerative colitis. However, what is called the true love regimen is used in acute fulminant ulcerative colitis, when the patient gets hospitalized, in spite of the mesalamine and oral steroids, the patient is not going into remission. Then we admit the patient and put the patient nilperoral for 5 days, only parenteral alimentation, systemic steroids, and then see what happens. If then also they don't go into remission, then we have to initiate biologic therapy. So the enteral elemental nutrition does not play a big role in ulcerative colitis, but can be of avail in Crohn's disease, but not really important.
Sir, Dr. Jitendra Kumar Dayal Shah from Gujarat is asking, sir, what is the dose and duration of vedolizumab, route of administration?
Route of administration is intravenous, again in infusion. So you can just refer the latest therapeutic guidelines. They give vedolizumab. Just go to the AGA 2020. They give all the doses. Everything is there.
Sir, I have another question from Dr. Smith Kumar Vagasia from Andhra Pradesh. He's asking HBV positive, HIV positive, TB positive with immunosuppression, how to manage?
Wow. Okay. So if somebody is immunocompromised, how to manage? Yeah, it's a great challenging question. So because already immunocompromised, I think you'll have to go for selective drugs like even vedolizumab is preventing the rolling over of the cells, inflammatory cells. So it just only acts on the integrin pathway, integrin JAK-STAT pathway. So, the integrin pathway. So, and the other drug is the tofacitinib, which acts only on the JAK-STAT pathway. These can be used safely because the others might not be probably the answer. And then, see, basically you start with high dose mesalamine and then add on a locally acting steroid like budesonide. So 9 milligrams, 3 milligrams 3 times a day if it is pancolitis, or 9 milligram in control release formulation if it is a distal colitis. Then high dose, mesalamine and give rectal enemas, and then try to see if they can come under control. If they don't come under control, one drug which can be safe in this situation is vedolizumab. And then once the tofacitinib becomes available through the JAK-STAT pathway, that will be a very good drug. So which will be only focused there. So there is no problem.
Okay, another question from Smith Kumar. He is asking AZA-induced pancreatitis, bone marrow suppression or remission, how to manage?
That's a very difficult question. So azathioprine-induced pancreatitis and bone marrow suppression are a problem. So pancreatitis is treated as such. You take away the offending drug and then it, starts improving. There is no problem. And then, you can, in bone marrow suppression, it's really scary, nightmarish. So sometimes bone marrow transplant has to be given if the bone marrow doesn't recover. So that is the biggest problem. So you have to be very careful. As far as pancreatitis, yes, it will settle down once you remove the offending drug. Sometimes the bone marrow suppression may continue in spite of your treatment. So you have to bring in a hematologist also there. Try giving GM-CSF to improve the WBC counts and platelet counts and see whether GCSF or GM-CSF, Neupogen GCSF can help. If it doesn't help, if still the marrow doesn't come back, you'll have to go for a bone marrow transplant. It could be a permanent damage on the marrow. That situation is extremely uncommon. So we don't see often. That is why we don't want, we combine a biologic with an immunosuppressant drug like thiopurine, azathioprine, and then try to stop the azathioprine and continue only on biologic therapy for prolonged periods of time to maintain remission.
Sir, we have a question from Assam. What are the steps of present day TMT of UC?
Talking about the drug therapeutic monitoring, so I think you'll have to measure the drug level availability in the blood. So may not be available in all places. So that again is a problem. And to the question on Vido, it's the same dose as the TNF-alpha, 300 milligram intravenous, like 300. The infliximab, similar dose, 300. But here it's a single dose, 300 milligram. That's what is done. So whereas Inflixi, you give 5 milligram per kilogram body weight. Generally, for a 60 kilo adult, you give 300. But here it is 300 milligrams as a single dose for all adults.
Sir, I think this will be the last question. For the people with UC, the pregnancy, children IBD management, any changes in the treatment? But this is by a doctor from Andhra Pradesh.
No, Inflixi has been found to be safe in the pediatric population also. They've used Inflixi, adalimumab, everything has been used. If the patient has to be taken to remission, they use biologics. Abroad, they very frequently use. We are a little scared of using, but then abroad they use regularly for inducing remission. And then maintenance can be done. Fortunately in India, the disease runs a milder course when compared to the Western counterparts because of the bad bacteria they have. They have more pathobionts with the type of diet they have. Whereas we have more symbionts because of the high vegetarian diet. Even the so-called non-vegetarians, they eat only non-vegetarian food once in a week, where basically all of us are vegetarians. So that way, the more complex carbohydrates helps in the formation and perpetuation of symbionts in the gut mucosal barrier. So, and also the turmeric that we use all our foods, it's also a great help in changing the flora positively. So our ulcerative colitis mostly is a milder disease when compared to the West. We're able to contain the disease without going even for biologic therapy in many patients. So even the pediatric population respond very well here with our type of diet and microbiota. Fecal microbial transplant has been studied in pediatric population, also in adult population, and has been found to be very useful. Probably can even avoid, biologics by giving fecal microbial transplant. And future is very bright that we'll get live biotherapeutics, which will be engineered.
Thank you very much, sir, for this nice presentation and taking your time out on Diwali to spread the knowledge, the light of knowledge. And thank you very much from our side.
Thanks to Omnicurus and thanks to all the brave souls who joined us on the Diwali Eve. So wish you a very happy and healthy, safe Diwali. So see you soon in some other presentation. Thank you.